a real problem. Eh? And we explain here why you have hemorrhoids or piles, so-called vascular cushions down there. Why do we have them down at the lower end, at the inner canal? Huh? Sorry? You look like you're getting interested. You start to think. Huh? We told you it's to prevent any liquid stuff, like when you have diarrhea, so we don't mess up our underwear. Yeah? Those act as plugs to prevent soil and liquid escape. Eh? You follow? So as it was in the beginning, at the end, that was at the end. So at the gastroesophageal junction, what we have? We showed you the picture. Huh? No, I say we have vascular cushions, usually 3 in the lower end that come together like that. It's the hole and the 3, the mucosa raised up by these vascular cushions, as it were. Plug the hole, you understand me? Sure. So what happened at the cardioesophageal junction? I showed you in the picture. Those were the lectures, and I mentioned it. It's the so-called mucosal rosettes. The mucosa is thrown into rosettes here because of the venous channels that are coming up from the gastric. So you have a plug, eh? I think I've been through most of them, yes, sir? 5 to 6. Okay. At the lower end, we have a nice, big, tough sphincter, which I showed you. Mr. Gardner showed you in his lecture, and I showed you yesterday. Yeah, the lab, right? The sphincter, right? The pylorus. And what controls the opening or relaxation of the sphincter? Brother? It looks like you guys not coming to the lab and the lectures. Anybody can tell me what causes the relaxation of the pyloric sphincter? Mr. Gardner said it in here, and I said it yesterday again.
The difference in, it would have to be the difference in tonicity and also vagal input.
It's a vagal input, in which vagal nerve controls the pylorus. Mr. Gardner said it several times, and Chalky, I think you have to go and allow all of these people to live at home with them, so they can hear every day. What vagal fibers control the opening of the pylorus? You told them, right? And I repeated it. So I think you better, he has a nice home on the hills, by Beverly Hills. Cool and nice. So I think you better take them in and give them evening lessons strong. So we have 2 vagal trunks. Have any of you seen a vagal trunk yet? Huh? Yes, man, I showed you yesterday. Didn't I not dissect it out, the anterior vagal trunk? Did I not dissect it out yesterday?
Yeah.
You were here yesterday, brother? Talk the truth, you were here? That's the trouble when you don't come. Don't miss these things when the big boys are chalky over there. Please don't make sure you're not. The only thing that's supposed to keep you away is bad sickness. Eh? So we showed you the anterior vagal trunk yesterday. Yes? And my sweetheart there, that little cute girl. What's her name? What's your name, love? What's your name? Nesta. Nedfa? Something like that. Anyway, Nedfa. Or Nesta. Did anybody with the name Nesta? Apart from Nesta Carter. Bob Marley. Yeah. What are the branches from the anterior vagal trunk? Huh? You were here yesterday? That's why I don't recognize you. And I'm showing you why you must miss these things. Eh? Because they're going to have a real life lab. And what we present in the exam are things that we show you. You understand? So make sure you come now. Tell them for me, Anthony.
Anterior lives of Lodenqai and the hepatic branch.
Right. And the mnemonic is AH. You follow? The anterior nerve of Lodenqai and the hepatic branch. So the hepatic plexus, the hepatic branch goes, right? And from the hepatic branch, plexus, a branch will descend to eventually reach the pylorus. And it causes relaxation of the sphincter. So that's it, the answer there. So we have the upper and lower end. It has two surfaces. Does this stomach have two surfaces? You guys are eating too much like me that night today. I'm sleeping now, you know, always sleep. It has two surfaces, namely the anterior. You don't need to write that down. I'm trying too hard. Probably I need to do like when we were little boys, run down the girls and try to kiss them all night. Then we'll try to wake them up. Now the boys in there.
Only one somebody read this again.
Say that again.
Nothing.
But she said she only want one person here to kiss her, me.
No, oh my god, I did not say that. Oh my god.
Okay, that's right. You see, I hear wrong. I heard wrong. Okay, there's anterior and posterior surfaces. Huh? Does it have curvatures? How many curvatures? Namely, less and greater curvature. Does the stomach have notches?
Yes.
How many? I'm hearing 2 and I'm hearing 3. Let me hear 2 first, because 2 come before 3. Right, so you all know about the cardiac notch, the angularis incisura, right? Somebody mentioned 3. Who mentioned 3 now? Don't be shy, because you're right. The number 3, who said 3 is right and the 2s are wrong?
It's crazy.
What is there going on? I don't guess. Right, we don't mention that too much to you. But there's that 3rd notch. What is the other name for this notch? So we know about the cardiac notch, no? Angular incisura, you know about that. Right.
According to Orin.
These are ring. That's Orin, right?
Yes.
Wait, Douglas Orin is your old man? You know of him though? Douglas Orin is a very affluent Jamaican, you know? He was at my school. And he was a very bright guy. And he ended up being the president chairman of this big company, Greece. You all know about Greece, a big company. So what, you're a whole mirroring? One of you girls are a whole mirroring yourself? Huh? One of you girls are a whole mirroring?
He's next door.
Sorry? Okay. Intermediate are so-called sulcus intermedius. So there are 3 notches. Huh? Now, the most important of these 3 notches is the angular incisura, right? And anatomically, how you find it? We know it's on the lesser curvature, but how are you going to find it on the lesser curvature? It's hard to define it. Here it is really the angle that we intersects with the angle of that. The descending angle versus the oblique portion of the lesser curvature, right? And Mr. Gardner will highlight it to you that this angle And what important pathological thing happened at the stomach there. At this angle, angular is not an important, very important pathology develops here. This what develops there.
I think we put the red pointer.
Peptic ulcer develops at this point here. Along the list. So it's at this point that it's so-called typical chronic benign gastric ulcers. You understand me? But I say, Mr. Gardner, I told you, but without understanding, it goes through the head. You understand me? Why does it tend to develop at this point? You with me? Why does it tend to happen at this point? No, you don't know why. So I'm going to explain to you why it tends to happen at this point. Just like how the upper sphincter can become incompetent, similarly the pylorus can behave and become incompetent. And when that happens, that is going to reflux into the stomach. Now, the most irritant of the natural occurring juices in the alimentary tract of the stomach is bile. Bile juice, nearby.
Even then, what is through the hand?
And this is why it's so powerful and strong.
Your stool is behind it.
Yes. So Mr. Gardner tell you when you eat that food, it goes down a special part of the stomach, that's all. What do you call that? Right, the Magenstrus. You heard about that kind of, right? And similarly, when the bile reflux, it goes along this part. Follow? And it's irritant to the stomach. And anything irritating you, just like when I'm checking Crystal and Chalky,
Yes.
she was around to get rid of me.
No, she wouldn't do that. She's a
Yes,
nice
no.
person. No, man.
She
No.
pushed
Never.
me on.
No.
Eventually, that's how the girls do
No.
it. And eventually, we get the
Very
message,
nice.
you know. But the stomach is being bothered by this bile that's coming up, you know. Keep bothered and bothered and bothered. And to prevent against, or rather to overcome, it will produce more mucus. Mr. Gardner showed you the mucus cells of the stomach, right? And we have plenty down in the antral region. Which makes sense, you see? So the body reacts with hypertrophy of the mucosal cells there. But after a while, what happens? You keep bothering you and bothering you and bothering. Just like when the mosquito is bothering you. And after a while, when the mosquito is bothering you, and you try just push him and so forth, after a while, when you sleep overtake, you just say, have what you want, mosquito. I take a sleep and the mosquito enjoy himself and meal off. So it will keep irritating. So it moves from hypertrophic state to an atrophic state now. We cannot produce no more mucus, or rather producing less. Become an atrophic state. And whatever little acid and pepsin that's around will start to erode at that point. But what's happening here? Along the lesser curvature, rules to apply as far as the blood supply is concerned. That's all. What is the rule of two along there now? Lesser curvature, man, not hard. There are two arterial supply. One by the right and one by the left, and it was joined, don't it? Make sense? But having said all of that, is there any peculiar arrangement of the blood supply from these vessels to the stomach? No, you won't know, but I'm telling you for you to understand. In the antral region, the blood supply is in the form of a plexus. And within that plexus, there are a number of, Mr. Gardner mentioned this to you, I'm sure. There are a number of so-called arteriovenous shunts. There, he mentioned it to you. Who shunts are these again? Who?
Emissions of Haller.
Haller. Alex von Haller.
Hello.
The first, I had the privilege of working with the third. I'm not sure if he's still alive or he was older than
I think he's still alive, you know.
He He's the big boy in pediatric surgery at the Mayo Clinic.
Right. I'm guessing.
And when Jamaica was progressing, I said was. The guys from Mayo would come down and work with us. And there was a little
Teach.
boy, first year resident in pediatric surgery here when he was here. So I'm rubbing shoulder with these big boys, Alexander Van
Haller the third.
And he described his arterial venous shunts. But those were the good old days of Jamaica's in the 60s. But our friends down on the southern campus, the social scientist people, they wanted to be forward, but I think they forward in the wrong direction. They forwarded into the spore business, the color business, yellow power. Down in the southern campus guys out here, they advocating for the black power at that time movement. And it influenced the little boys them down from down August Town and towards the other areas. You understand? They want to show that they have power. You know what these guys did? They go and raped Alex Van Hollen's wife. They were living in the
Across the road.
across the road, college. Yeah. They're going to rape the poor lady. And that was the end of the story as far as UWI and the Mayo Clinic was concerned. End of story there. So plexiform near the arterial venous shunts of Haller. Whereas above this angle incisorius, the arteries are not on the plexus, but are in the form of end arteries.
Answer, come right here.
You follow? So
You
right
listen
at the
to that,
angle now,
right here.
you see there's a watershed.
You need a
area
stool so you can stand up
in
and
that
sit.
plexiform blood supply. And then in that
A
area
stool.
where there
I mean,
is
something high.
the steer is on the susceptible.
No, here.
You follow? And this is why when you get the ulcerative process starting there, then you will
On
be
the stool.
heated and it generates gastric ulcer.
Use that stool.
You ready for the blood each
Yep, yep.
You are ready for
Yeah,
them?
man, ready now.
You can fix it. Relax your liver. Yeah, man. It was right as a not you alone touching me.
Already did it already.
I think I make sure we film it. The church will make the we are something like this. I need to say when one day one of the
That
feelings
sounds
like
good.
the mute you.
Okay, that's
That
good.
sounds good. You can hear me. Yeah, man, we can hear you. You will. Okay. And your name, my dear?
Hello.
Alia. Alia. We had two students last year named Alia, you know. Two. Yeah, one sat right up right there. Alia from what? Bahamas. Isn't that what, Patrick?
There was an Alia last time.
Alia sat right there last year from Bahamas. And then another Alia sat right here.
Yeah.
Two Alias. And then Alia. Do you have any students from Bahamas here? No? Or not? Really? No Bahamian?
Bahamian right here.
Okay. Just throw this in the treatment. A Bahamian there?
Yes.
Alright, just take this away from me. Just put this on the top of the other one. Alright, so I remember as a student, I was doing my anatomy as a student, that hoping that you have that, Patrick, that you have the visual power. Okay? So I remember I was in the old gross anatomy lab, we were doing abdomen. Okay? And I was walking to where my group is. I'm a student in doing anatomy. And right over there, there's some cubicles right on that side, and some cubicles on this side. And right over there, looking right down there, was my head of department then, Dr. Fletcher. Okay, so Dr. Fletcher. And colleague Patrick, they were opening an abdomen. And that abdomen had a mega colon. When the colon was like that. And we're coming in descending, coming down. What part do you think that we did? Maybe descending. This was the diameter of it. This was the diameter of the colon. Two points, what the heck is that? As a student, big thing. And then now he was doing some further dissection and in the supracholic compartment. And I looked over, and today I still see it. I'm hoping that when I show you this thing, you will remember it. What was I looking at? You look at the celiac axis. So the celiac axis, and I can still see the cadaver and see the celiac axis. All right, the celiac axis. Okay, so let's see if we can see the celiac axis. Okay, so I'm hoping that so we zoom in now, so okay, so we want to fill up this space now. Alright, so we want to fill up this space with a little. Good. I don't want it to go so slide down, you know, Patrick? Okay. Okay. So Alia. Okay? Alia, come over more with the thing though, you know, the camera. Because this time we have to show some very important things, okay? So Alia, zoom in harder. More. Okay? So it's looking good, love. It's looking good. It's looking good. Alright? It's looking good. Give it a chance. Okay, what I want to do is to see this vessel right here. So, Anthony, come, stand up quick. Quick lightning, man.
Yeah, man.
Take the red pointer. This red pointer. Right? And point at that vessel. Gently, this one. Right. Okay? So you're looking at the celiac. Reverse off of it a bit. Good. See, that's a celiac trunk. So what is it coming off of? What's the big parent vessel down there? It's the abdominal ear. No, keep it in it, just gently. So when you look at this, forget about it. When you look at this, what shaped letter are you looking at?
A Y.
No. A T. Okay? So you're going to observe that there are many T junctions. Lord, give it. That's what you examine. The person made us call and call back. I'm in a class, I can't talk to you. Dead story. Give it a minute. Just give it a minute, all right? Perfect. Okay, so I want you to take a picture of this, okay? Come.
Is it coming on the exit?
Yeah, you're young people, young and brand new and fresh. So there you're seeing this boy that's emerging from off of the aorta, and that boy is the celiac trunk. And you notice that he's forming a letter T. No man, don't worry about writing, you know. What you want need are pictures, and label the pictures, don't write nothing. You are wasting your time. You're achieving zero. Look at it. So you see that big boy. This big boy here is called the celiac axis. Alright? See where he's coming off from the aorta. And that celiac axis, we'll see now is divided. Come off back a little, Alio. Reverse. Good. It's coming over, and it's a letter T. And one branch is going to the right, and one branch is going to the left.
Oh, no, I see.
Yeah? One branch is going to the right, one branch is going to the left. Okay? So the right, come back off of it a bit. Right? Off a bit more, and we're going to come back down. See the liver? See the gallbladder? Yes? See Pringle's maneuver right here? See? I have my index finger now in the what? In the epiploic foramen. See the epiploic foramen right there? So we are relaxing. So that's the celiac trunk. Back down on him again. Okay. All right, that's the celiac trunk. And coming over to the right would be which vessel?
Common hepatic.
That's the common hepatic artery. Anthony, come and look at the thing. Right beside me over my shoulder. So that's the celiac trunk. This is the artery to the foregut. The artery to the what? The foregut. Okay? So where will he end his supply? Where does the foregut end?
The distal part of the transverse colon.
Eh?
Distal part of the
No, this no man.
That's the end of the
Proximal to
So the major papilla.
Right, major duodenal papilla. Okay, it's going to that level. All right, now watch here. Then you see, watch here. This is a common hepatic artery. And then, what is it doing again? Making another letter what? T. And this T is ascending, and that T is part limb of the T is descending, capital T's. Right? Okay? Therefore, the T that is ascending would be who?
Common hepatic.
Come down and in. Let me just come down and in. Huh?
Proper hepatic.
Yeah, come down and in. Right. Good. Yeah, see there? Then the vessel that is coming. Alright, look at that. You see him, yes or no? Just tell me no, because I'm manipulating. You see they're sending this branch? What is that branch called? Right. And then Alia, look what we have to show them, sweetheart. Alia, look here, love. No, look here. I want to show them this. So you have to help me, you know. Right, you have to help me, love. Because we have to show them this thing. See what I'm holding here? And I want you to show them that it's dividing into these two branches. Ah, beautiful. Come down on it. Max. So this one is the left hepatic artery. This one is the right hepatic artery. So this is the proper hepatic artery, dividing into the right hepatic and the left hepatic. Look at this. Come here beside Anthony. Anthony, quick man. What letter are we looking at? What letter are we looking at? No man, on the specimen, don't forget it on the screen. What letter is that?
A V.
Yes. Could be a Y because it has a longer thing coming down. Yes?
Yes.
So this is coming from the liver. So this is a common hepatic duct. No man, look over my shoulder, common hepatic duct. Then this is a gallbladder. That's a cystic duct. It looks good on the screen, yes or no? Just tell me, you have to tell me no.
Yes.
That's a cystic duct. And then, so we're in a triangle here called Kalos triangle. And in that Kalos triangle, we're seeing the cystic artery. See the cystic artery right here? So this is a very important thing. This is Kalos triangle right here. So there you see the gallbladder, that's the fundus. Okay. Right? So Anthony, it's just alcohol and steroid. Just feel it come up with your finger.
With my finger.
Come here, man, tough luck. Come. Yeah, there. What you feeling? Gallstones. What you feeling then?
Yeah,
gallstones. So, when his father did anatomy, you know, when his father did anatomy, and from the last, for about 25, 30 years, my first 20 years in anatomy, no gloves were ever used. And we were down in all the fat and adipose tissue, and your whole hands were full of oil. Cunningham's at a manual, this was beside you, and every page of your Cunningham's manual became translucent. The oil on the Cunningham, right? Okay? So there, that is the cystic duct. This is the common hepatic duct, and therefore, who is this big boy here? CBD, common bile duct. And see, we have pushed now the forceps into the epiploic foramen. And we see anteriorly CBD, anteriorly and to the right, the proper hepatic artery. And then if we go back down again, so Al, you follow me, sweetheart, you have to help me. right? Because we're going to, our mission is that these students must know this, right? Right there, what is springing out? What's springing out? The celiac axis or trunk, lower border of T12, dividing into the vessel that's going to the right, which is the common hepatic artery, and the one that's going to the left, splenic. Common hepatic is dividing into a vessel this descending, and that vessel descending is a what? Gastroduodenal. And we see he's giving off some branches, you know. You see these branches here? Supraduodenal arteries of Wilkie. Supraduodenal arteries of Wilkie. Right? So, if you just look at the pylorus here. Anthony, feel again, come. Right over my alcohol, this is very good. No, grasp it.
Grasp it.
Grasp here.
Here?
Yeah.
Yeah.
What you feeling? The pylorus.
Oh,
Right? Feel it? That's a pylorus. Okay, let him go. Then this is now pre-pyloric vein of Mayo. So when you look at the pylorus, that's the first part of the duodenum. See there?
No.
All those structures are behind the first part of the duodenum. All of those structures are behind the first part of the duodenum. Okay, so I see a little boy running and paralleling the common hepatic artery. Who is this boy that is traveling with the common hepatic artery? Right? Who is this boy that is traveling with the common hepatic artery? Who is this boy traveling with the common hepatic artery? Right here. Hmm? Who is that artery there? Side. Right. Yeah, who is this artery that is paralleling it? There. And that artery is a right gastric artery. And look how tiny it is, like a thread coming from the proper hepatic artery. See him there, springing up from the proper hepatic artery. Okay. All right. Okay, coming right back up now. Okay. Anthony, just hold it up on this cloth there for me. Excellent, because it's sliding down. You get what I mean?
yeah.
Yeah, Bobo. Now, look down in the depths. I pick up the celiac trunk, and I see there's a big boy coming off the celiac trunk. Right? Wait a while. See the bugger right here? That's him right here. Sorry, that's the boy here. Well, I'm seeing a vein beside him, but that boy, you see this boy? Yes or no?
Yes.
Yes. See the boy? So this is the third branch of the celiac trunk. And who is he?
Left gastric.
The left gastric. See the left gastric right here? And if we trace him up, watch what he's doing. He's going to form another letter T. See another letter T right up here? Right here. See the T? Yes or no? Well, Alia has to push it. It's not Alia's job. Alia, this is a very, we have to work together. See, you have to look what I'm looking at, sweetheart. And then no, look down at. So that coming up from the celiac trunk ascends and then divides into this big boy. This big boy is the left gastric, the continuation of the left gastric onto the lesser curvature. Look how big he is compared to the thread. That is the what? Right gastric. Okay, and then now we'll see that the left gastric forms a T, and that T is going to form an ascending branch. See, it's ascending, and that's going to supply the lower third of the esophagus. This artery supplies the lower third of the esophagus. This artery is going down into the left lesser curvature of the stomach, and boy, he's big. He's a big, big boy, right? Okay, and there we can see him coming right across. Okay, and there we can see now, who is this there for? That is coming and traveling with him.
Left gastric vein.
Left gastric vein. Draining directly into where? HPV. Right, going directly into the hepatic portal vein. Right? Yeah. So there is the most important thing is the demonstration of the what? The celiac trunk. See the boy there? Rising right above the body, the pancreas. See him right down there. And then if we reflect, if we do some reflection here, so there's this stomach, and there is the fundus of the stomach. You see how height goes up? Look at that. So it's all, look inside of it. See here, there's no rugae or nothing there. Right? So what is right there? What is right contained in there? You tell me. What you said? Gas. Gastric bubble. Right? So that's the gastric bubble. And what lies directly on this, just like a little sheet, what lies on top of this? Diaphragm. Right, that's diaphragm. Okay? That's the diaphragm, the dome of the diaphragm. And who is lying right here? See, like that? Just like that. Who is lying right here? The heart. The apex of the heart around there. Right? So many times the gastric bubble will kind of push up, right? Become too large and press, too compressed, put too much pressure on the heart, right? And the person feels like they're getting a what? Heart attack. What syndrome you call that? Anyone? If you don't know, then you're elderly people at Golden Age home. If we don't know, we might as well get a bag and carry them down to Golden Age home. So we have some new patients. Because I lectured on it, I talked about it in the lecture. The syndrome. Gastrocardiac syndrome. Right. Many patients are misdiagnosed and they don't know that there's a heart problem and the patient has been treated for stomach or vice versa. Okay? It happened to my best friend, lived on Marley Road. The doctor was treating him for stomach things, issues. Right? And Ronnie Kenny says, no, you have to go in and get a proper ECG and go into the hospital. He didn't listen to him, went home and found dead in his bed. Massive heart attack. Okay? Very good. So many times you have to be careful with the patient, right? That you're not treating them for the wrong thing. Okay. All right, so very good. So let's get back on it and have a little one here. So we see the stomach there. All right, and now hanging off is the greater omentum, and this portion here is the gastrocolic ligament here, or gastrocolic component. And then that's going to, that greater omentum swings around to be continuous with the splenic ligament. Isn't that so? So there we can see that's the transverse, and there is the what? The greater omentum. So you see that this has a bit of a hypertrophied pyloric sphincter, right? So some patients, and I'll show you, I think I have one that is even worse than this. And then these patients now, in the night, there's the sphincter can't release properly. So when they go to bed in the night, wife and the husband, all the wife is hearing so what do you call it? Abolishing sound. Right. So we have to do some now pyloroplasties and that sort of thing. You have to try to, eh? So what is happening? The release is very, have a very hypertrophied sphincter, and everything is becoming like a factory inside. And you can actually see on the patient the stomach is going, and look at the patient and you see the patient's abdominal wall going like a dancing. And going, and then no, he says, oh my God, what is this man I'm married here now? I should not say that.
Those gases are up your other end.
Yeah, terrible. So right here. So there we come around and see now. So we're just having a little fun here. We come and we reflect. We reflect. Okay? But just to say, just to take, and Dr. Lodenqai is going to deal in great detail, but just to come around and to make out now the head of the pancreas. See the head of the pancreas here? Zoom in hard and low. Situated in the C shape of the duodenum. Okay? And there we can see, and we open it up now, and we open up and we open up. I'm coming back to my area, and we can see now the major duodenal papilla and the minor duodenal papilla. Okay, so Dr. Lodenqai is going to deal with all of these things. Reflect back up gently, and we see the superior mesenteric vessels, third part of the duodenum, and the aorta right behind with the inferior mesenteric artery. Okay, leave this all alone for a while. Dr. Lodenqai is here. Pass out the tray there. The tray. But the important thing is that I've shown you crystal clear the what? Celiac trunk or the celiac axis. Okay, just relax. So Anthony, the celiac axis comes off of the abdominal aorta at what level?
T12.
Lower border of T12. Very good. Lower border of what? T12. Excellent. Lower border of T12. Okay. Who comes off at L1?
Superior mesenteric artery.
L2. Renal arteries. L3.
Inferior mesenteric artery.
The ends where? Ends at L4. It bifurcates at L4. And the IVC is formed at L5. Very good. Cisterna chyli. Where would you find the cisterna chyli? Where do you find the intestinal trunks drain into the cisterna chyli? Right, together with other things. Where's the cisterna chyli? Lying on lumbar vertebra L1, and sometimes a little lower. So the celiac nodes are very important. The celiac nodes are going to receive the lymphatic drainage from the stomach through regional nodes and go into the cisterna chyli through intestinal trunks, etc., and then go up the thoracic duct. And the thoracic duct is going to enter. So spread of cancer. So spread of cancer obviously is, once you're dealing with gut, where's the spread of cancer to, Anthony? So radiologically, once you have any there, where's it spread to?
Lymph nodes.
To where? Which organ? So watch here, all down there. Which organ now?
From the
Liver. Everything is going to the liver, right? Colorectal cancer, everybody's going to the liver. Why, Anthony? Why?
lymphatic drainage.
More venous, Patrick? Venous. The hepatic portal vein. Oh my God, I didn't show you the most important thing on this vessel. Sorry, my apologies. Okay, so the most important, first, this most important is the celiac trunk, but even more important to see is we have to reflect down here. So you have to help me a lot, you know, Alia. You have to help me a lot, sweetheart. So there you can see now, this is a common hepatic artery, right? That's a common hepatic artery. So Anthony, hold it up here again. Yeah, hold the cloth. Yeah, the cloth. Very good. Just relax. There. Now look right here, students. So that's a common hepatic artery. Anthony, just take another finger on there.
No, yeah?
Yeah, excellent, my friend. So that's the common hepatic artery.
I do want to question.
There, relax. Pringles maneuver, yes or no? Yes?
I can't really see.
Who is this boy? That's a gastroduodenal artery. Who is this boy? Who is that? So watch here. I take the pylorus of the stomach When I reflect the pylorus of the stomach, who appears? Neck of the pancreas. So write that down, Crystal. Pylorus equals neck of pancreas. Mathematical sign. Pylorus, write it down. Pylorus. No man, I don't see writing. Pylorus equals, that's a mathematical sign. Neck of pancreas equals HPV. Right?
Human papilloma.
So there's the neck of the pancreas. Look at the neck of the pancreas. Watch here. It's being transected. And when you transect the neck of the pancreas, who appears behind? Look at that massive vein. And that is HPV. So all that we're eating, listen to me, everything that we're eating and everything that we're eating, products of digestion, everything. No, products of digestion and everything go to where? This boy, HPV. And if that's HPV, who is this boy right here? Who is that boy right here? Superior mesenteric vein. Right? Superior mesenteric vein. And who is this boy over here? Splenic vein. So that splenic vein, if we trace them further along, we would see the inferior mesenteric vein joining in, draining the what? The hindgut. Okay? The superior mesenteric vein right here, joining the what? The splenic vein. Where is the union occurring? Posterior to the neck of the pancreas. See the neck of the lobulated pancreas? So when you transect there, good. This is sometimes referred to as the tunnel of love. What the hell? People agree? The what? Tunnel, it's called the tunnel of love. Really know what is happening behind there, right? But Crystal, it's something good. The tunnel of love. Okay? So there you can see that. Okay, so there you can see now the HPV, splenic vein, and the superior mesenteric vein. All of this is occurring posterior to the what? Pylorus of the stomach. Alright, and there you can see the gastroduodenal artery passing posterior to the first part of the duodenum. Okay, so we're finished with this specimen for now. It's Dr. Lodenqai. I'm still in the land of the stomach, right? Still in the land of, so look at this here, look, Auntie, don't worry, wipe your hands, look here. Makes no sense to wipe your hands. Okay? So, Anthony, what are we looking at here?
The rugae.
Rugae. Right? And if you zoom in hard on it, zoom in really hard on it, because I know I need my reading glasses for this. But you zoom in hard. Look at Anthony, look. Do you see any little holes in it? You have to look down close, you know.
Yeah, I'm seeing them.
You see them? Those little holes you're looking at there are the gastric pits. Right? So in there, this is all of the little holes in there are called the gastric pits. So these are submucosal folds. Not mucosal folds, you know what? Submucosal means they have mucosa and submucosa. Now, always in the exam, always there, 101 times.
So what?
Look what's in the exam. It's turned around like that. You watching me?
Yeah.
And lecturer X puts pins, blam, 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 blam. Wait. Okay, wait, no, we don't see properly there, Alia. Alia, look what I'm trying to show them over there. Yeah, so this is in lesser curvature. There's a greater omentum. And therefore, this little highway coming down is called the what? Magenstrasse. Right? See the Magenstrasse? And then right here, incisura angularis. Incisura angularis. Okay? Then right up here, we're having fun. So Anthony, take your little finger and push it right up here.
Oh, wait.
Yeah, right here.
Oh, like
Yeah, right up. No, the other way. You have to come this way.
Okay.
Right up there. Look at that. Right? Where is he in now? The esophagus. So that's the cardioesophageal junction. Relax. No, put the finger back. So who winds around to squeeze that area? So who winds around to squeeze that area? So my friend now, the wife, has just had a little baby. Every night I get about 40 pictures of the baby. 40 pictures. That's little Ella. Right? So, and he sent me a lot of pictures. And he telling me, when Ella feeds, all the time she's bringing up the milk. Okay, so when burp around the milk is going down his back. Okay? So that sphincteric mechanism has not really, put your finger back here, not properly developed. So, what is winding around your finger to keep this closed? One of the things, there are many factors. What is winding around here? Crystal, what is winding around here? The right crus of the diaphragm. To form what kind of a mechanism? Pinch cock. Correct. What kind of mechanism? Pinch cock. So the right crus of the diaphragm, which is arising from L1, L2, L3 together with the intervertebral disc, winds around the what? The esophageal opening, cardioesophageal junction, and then continues on. What does what structure behind? What structure behind does it continue on as? The ligament of Treitz. Right? Crystal, write that down. Crystal, write it down. Ligament of Treitz, continuation of the right crus of the diaphragm. Suspends the DJ flexure. Suspends the junction between the duodenum, fourth part, and the jejunum. Take him out. Excellent. You can relax. So when we're coming around and we see here now, we come around here, what we look is that this area kind of look different. So this is the area of the what? Pyloric antrum. See the right, Patrick?
Yeah.
That's the area of the pyloric antrum. And it doesn't look nothing like that. See up here? When we come around here, that's the area of the pyloric antrum. So when they're doing a vagotomy, right? Dr. Lodenqai can talk to you about the vagotomy. He has done many in his life. You see them, the surgeon put a big thing around here. So my friend sent me a big thing, and he does an antrectomy. Okay? Or an antrectomy. Now, when we look here, so Alia, you have to help me out a lot, sweetheart. Right here, look at that, love. Coming zoom in hard. 300 marks. Look at the thickness of the wall of the stomach here, and look at this thickness right here. See the thickness right here? That's the circular layer. So we have cut, like this is a pyloroplasty. You have cut right into the pyloric sphincter. See it there? Oh, this is, and that's the circular layer. So look at this here. Come and look here, Anthony. Watch here. Look at this. This is the diameter, the thickness of circular and longitudinal. See how much millimeters you say that looks like? I would say maybe like about 2 millimeters in thickness, is that right? Right? And when I come to this, over here I'm looking at about 4 or 5 millimeters in thickness. And that's just the circular layer. Outside of that is the longitudinal layer. And then there's a man by the name of Anthony. Anthony, rub here. Just rub there. Yeah, gently, with your finger. Yeah, man. What you rubbing? When you rub like that, what you rubbing?
The longitudinal layer.
No, not at all. That's why I asked you to rub it.
Circular.
No.
It's both.
What you rubbing?
I can't see you touch it.
Yeah, what's he rubbing? Rub all of that. You get some good cadaver and the girls are going to love you. Then he said, Mr. Gardner, you're not doing anything good for me, you know. It's all right, it's alcohol, you know. You know, sometimes you have to be careful with students, you don't see them come back to the tutorial again. Not a tutor. Who wanted that? So, Anthony, what were you rubbing here? Serosa. What is serosa? What is serosa? Eh? What is serosa? Melissa?
Type of connected loose areolar connective
No, it's a topic Dr. Lodenqai dealt with a whole heap yesterday. Visceral peritoneum. So if you open up your peritoneal cavity, you have visceral and parietal, right? The visceral peritoneum. So, Crystal, who I know can answer me, Crystal, what exactly is visceral peritoneum? Under the microscope. Under the microscope, what is it? Hmm? Peritoneum, but what would we see under the microscope? It's all right, go ahead, sweetheart. What we see under the microscope? What type of epithelium? 300 marks. Simple squamous epithelium. What's another name for it? A mesothelium. Right. Right? So the whole of your abdominal cavity is sometimes used for what is called a peritoneal dialysis. Because at present that is just a mesothelial lining, we can use it right for peritoneal dialysis. So some people every day they have to go for peritoneal dialysis. Okay? So that is there. So if it's on the inner lining of the wall, it's parietal. If it covers something, it is visceral. Okay? Tell me about the peritoneum as it relates to the transverse colon. Does it have a serosa, yes or no? No. Lord, I'm going to see these people, but with the transverse colon don't have a serosa.
Sir, you want one
Of
for
course, it must have. It's going right across. It's within the peritoneal cavity, so it must have a peritoneal lining. So therefore, this is a serosa, right? But the ascending colon, when it's going up, watch, and the descending colon, when it's going down, are lying behind the peritoneum. Yes? So they have in part a serosa and in part an adventitia, right? Because the part, so what's the length of the abdominal esophagus? What's the length of the abdominal esophagus? 25 centimeters?
No.
No, we have to get Von Haller here, Patrick.
That's the whole thing.
Bring these students up to live with you.
Eh?
They come there and live with you.
No, man.
They can teach them
So this is 1.5 to 1.25, half an inch. And does it have an adventitia or does it have a serosa? Does it have an adventitia? Has a serosa, right? And it rests on the what? The diaphragm. It's in relation to the liver, but the rest of the esophagus going all the way up just has a what? An adventitia. It has no peritoneum or nothing like that. Is it reasonable? Right. So relax. We're having fun, you know. Okay. So there we're seeing the stomach here. No. Look at this. So there we're seeing the stomach, right? And we can see once again the thickening to form the what? The sphincter, right? See the sphincter right here? And then behind the stomach now, who do we find? That's the spleen. So the spleen is right there. Watch the spleen. Posterior relation. We're looking just at the stomach, a little review. Can you give me a time signal? 3:11. In 10 minutes, I'm handing over to Bila then. Is that all right, no? 10 minutes. All right? So there we can see this is a gastric surface of the stomach, yes? So pass that split tray for me. Which one? Yeah. Right. Take it back, Anthony. Okay, so look at this person's spleen here now. So what you notice about this spleen versus this spleen? Splenomegaly. So this person died in a, what the crisis they call it? What kind of crisis, Patrick? What kind of crisis they call it?
Post-splenectomy syndrome.
No, when they oh my gosh, boy.
Malaria.
No, not malaria. What Jamaicans have a lot of? Sickle cell. So this person died in a sickle cell crisis. Okay? So this was a sickler. And he was a young guy. Very well associated with the university. And before he died, he said he wanted his body to go to anatomy. Okay? So sickle cell, a sickler. Okay? Giving his body to anatomy. Right? So boy, I remember that I knew a very beautiful girl. Very, very pretty. I mean, wow, she was so pretty. She lived right on my road. She was at university doing her master's in physiology. I was in anatomy, and when I was doing my anatomy, she was right over there in physiology. And she was such a beautiful girl. Her name was Annalise. And poor Annalise, she had sickle cell, right? And my friend, when she went into a sickle cell crisis, I remember visiting her in the hospital. She got married, you know, to a guy with a doctorate and brilliant guy. And it was very sad. You see all her eyes were all jaundiced and yellow and this and that and the other. I think when she was about 23, 24, she died. Her father was a doctor and everything, so she was getting the very best of medical things. But at 23, 24, maybe about a year after she married, she died. Yeah. It was a sad story. Annalise. So the sickle cell is a bad story, right? So she went into what? A sickle cell. Number of times she'd get a sickle cell crisis. Right. So this is a person who died in a sickle cell crisis. Okay, and you can see how engorged the spleen is with blood. Okay. Alright, you can put that up. Just that specimen. I think I forget to love the specimens here. Good. So, there, zoom in hard. Okay, zoom in down hard. And you can see we've dissected out the what there? Gastro, splenic, ligament. Okay, and then Dr. Lodenqai showed you another ligament yesterday known as the what? Lino-renal. So, when we reflect the stomach like that, reflect, who lies behind the stomach? Many things, the stomach bed. Okay, the stomach bed is behind it. But very important behind the stomach, because when there's gastric ulcers may perforate, erode away the wall and erode into the pancreas with a lot of things, and then now may erode into this boy. Look at this boy here. Look how big he is. This boy is massive. You see him along there? Look how big he is. See there, Crystal? Crystal, look at, stand up and come and look at this. Look right here, come sweetheart. Quick, line, fast. Look at that boy. He's big? Yeah, how is he shaped? How is he shaped?
Spirally.
He's described as being serpentine.
Okay.
Described as being what?
Serpentine.
I didn't hear you.
Serpentine.
I can't hear you.
Serpentine.
Very good. Right? So there you can see he's going all the way along here. And he's going to, there you can see the various vessels. And then now, who is he traveling on above? The pancreas. What part of the pancreas am I holding? The tail. And the tail will lie in the lino-renal ligament. The splenic artery is going to divide. So in that tail of the ligament, what are we going to find? The tail in that spar, in that lino-renal ligament, what do we find? Lino-renal. Tail of the pancreas? Yes. Yes or no? Splenic vessels? Yes. Any lymph nodes? So this part of the stomach drains to which set of lymph nodes? Always in the exam. Pin is right here. Lymphatic drainage is to where? Answer, pancreatico-splenic nodes. Pancreatico-splenic nodes, right? So there you can see the splenic artery. Okay, end of story. Your time. Oh, Pila next, watch here. Patrick, watch here. If you need, come and look at this, Patrick. Major. And you have everything there. So you clean out this here.
Other stuff.
Oh, yeah. Yeah, no, it's right behind you. It's just alcohol. So, just on the train. So, students, there are two sets of specimens we have. One in alcohol, so they're sterile, and the other one is in the informalin. So, these are sterile. You can't throw me up. See? There you go. So I'm handing over now to who? Who am I handing over to?
Sleepy.
Listen, who am I handing over to?
Sleepy.
Alex von Haller III.
Wait, Gardner. What was the thing that was serpentine?
Splenic artery. Like the waves on the sea. All right, the duodenum. Embryologically, the duodenum develops from both foregut and midgut. Yeah? And you all remember the junctional region between the four.
So I'll comment, Dr. Lodenqai likes when the young ladies put the thing on. I can't get him back, you know.
Oh, wait. Yeah, I see the pyloric.
Yeah, that's all right. So the junctional area between the fore and midgut is in this descending second part of the duodenum, roughly by the vicinity of the major duodenal papilla. Good. The duodenum we said was how many inches long? Or centimeters? Sorry? 25, yeah, centimeters or 10 inches long. And the duodenum, it forms a C.
What else is 25 centimeters? What else? Anything else, Patrick?
No, that's. Now, the duodenum, we said, was divided into four parts. The first, or the superior part, extended from the pylorus to the hepatic flexure of the duodenum. Yes? And what costal cartilage level is usually at that level? Yeah, I would give it a 9. And from that hepatic flexure, it will descend more or less vertically downwards to the inferior flexure. At what vertebral level?
L3?
Yeah, L3. And the first part was 2 inches long, or 5 centimeters. The second part is another inch longer, 3 inches, or 7.5 centimeters, yes. And the third part runs more or less transversely. Yeah? And it's another inch long, so that's 4 inches or 10 centimeters long. Yeah? It runs more or less transversely across at L3 level. And the last part, the fourth part, is the ascending. Usually it's about 1 inch, 2.5 centimeters, and ends at the DJ flexure. Yeah? And that angulation of the DJ flexure is maintained by what again? Ligament of threads. Okay. So, having said all of that, let's try and see where we are now in this specimen here. Okay, so we have the pylorus, yes?
Watch me before you sit so you can see that. Go, there.
We have the pylorus, and there should be a so-called pre-pyloric vein of male there, yeah? And the same guys that Mayer found that when you eat plenty, which I know we guys can do, especially when the food is good, tasting good, and free. Huh?
Start with free and taste it.
Like when you go to each other's weddings, man. The best wedding to go to is a Chinese wedding. You know?
Why is that?
Huh? We're talking about food here, you know.
So we're invited to yours.
Huh?
We're invited to yours now.
Mr. Gardner is trying to set me up to go on these girls, you know. I don't know if we should yet.
You're not making too much success.
No, they're not making too much progress.
So you can let us know when you had your success.
Chinese, when they're married, at their wedding reception, their meal is usually 10 to 12 courses.
What?
10 to 12 courses. And each course is usually involve a different dish, you know.
So I just take up the team.
Yes, they might have the first one they might have say chicken, pork, beef, shrimp, fish. Go down the line, you know. The last one I was at, I retired at 6, you know. Could make this journey. So the guys at surgery in Mayo, they found when the stomach is full. Yes, by what they did was pull down the stomach towards the left iliac fossa, as I'm doing there. And then look at the duodenum. They found a part on the superior part of the duodenum that blanched, yeah? You know when it's all blanched?
Yeah.
Becomes a whiter shade of pale. You know that song, right? No? You guys never hear about the whiter shade of pale, man?
Famous song. I don't believe you.
These guys are not much music talent inside here.
Crystal, write it down. Write it down. No man, write it down. Why you shade of pale?
That part of the duodenum.
Hold on. And the person who does it very nice, a girl called Lucy Thomas. She's about your age. She did it recently.
You can download and listen to it. on
Lucy
your phone.
Thomas. Voice, beautiful song. None of you know it?
Yes, yes. So John, come on, give a sample. Sing it for us.
Believe them.
The first part of the duodenum was blanched, became pale, as when you pull down on the stomach, or when the stomach is full of food. And the guys at Mayo describe that as the anemic spot of Mayo. And the distribution of the arterial supply to that area is telling us something, no? That is not so great, don't it? Eh? And that's the area supplied by the supraduodenal artery of Wilkie. Yeah, it's not so great. So, yeah, and that is the area we talked about a duodenum also being formed anteriorly. That's the area that will ultimately perforate freely into the peritoneal cavity at that point. Now the blood supply of this first part of the duodenum, right? The first part of the duodenum, the arterial supply, you need to know what's going on. Coming from below, yes? Remember we said the second part of the duodenum was the junctional area between foregut and midgut, yeah? So coming from below, That is the lower transverse part, third part of the duodenum coming up towards the first part. Was blood supply coming from the branches of the superior mesenteric artery. Yes? And these branches that are coming up are who again? You should know them by now. They run in the groove between the duodenum and the head of the pancreas. This is the duodenum here. And you can see the head of the pancreas in the C loop. Yeah? And usually have an arcade running nearby this groove between the pancreas and the duodenum. Yeah? So what are these arteries that's coming from below, Paul? They're the pancreatico-duodenal arteries. There's anterior and posterior, they're at the back there. And they are coming from below, so they must be inferior because they're going to run up and anastomose with the corresponding anterior and posterior superior pancreatico-duodenal arteries, which are coming, of course, from the gastroduodenal artery. Yeah? Yeah?
Hold on. Could you repeat that last branch you said?
Huh?
The last branch you said. Could you repeat it, please?
Superior part of the duodenum.
Duodenal arteries are Wilkie.
Yes, well, I mentioned that already.
After that.
And then I mentioned in the anterior and posterior pancreatico-duodenal arteries.
Very good.
The inferior ones coming from the superior mesenteric artery, both anterior and posterior. They might come from a common tract. Whereas the superior pancreatico-duodenal arteries, anterior and posterior, the ones which are going to anastomose with, are coming from the gastroduodenal. Again, can be coming from a single trunk. Right. So this is so far we have 3 arteries to the upper part. Turn on the volume. Got a feedback. Good. So we have 3 arteries so far, yes? Now, the stomach, Mr. Gardner showed you that one. Yeah, he showed you the right gastric artery, yes? And sometimes from that right gastric artery, branches are given which go to the right to supply this first part of the duodenum. So much arteries were gone, 4. And the gastroduodenal artery, which is sometimes referred to as the retroduodenal artery, because it's running behind the duodenum, no? So it's not inappropriate to call it the gastroduodenal artery, the retroduodenal artery. Some people do, some books do. But that artery, gastroduodenal, retroduodenal, will give off to the upper part, retroduodenal arteries. So you see where we have the first part of the duodenum there now, getting 5 supplies. Yeah, 5 arterial supplies named. Yeah. Now I mentioned to you in some patients, they'll unfortunately develop stomach cancer, and to cure the cancer, we resect most of the stomach, 2/3 or more of the stomach. Yeah. When we resect 2/3 or more of the stomach, you see whereby we cannot join up back the stomach with the duodenum that's left back. Yeah? So we will resect the stomach, 2/3 of the stomach, include all of the pylorus and the sphincter, and the first inch or so of the duodenum. So when we resect that, that is referred to as a Billroth 2 gastrectomy, in which stomach is resected and the normal anatomical continuity of the alimentary tract is not maintained. That is, do not get stomach straight to duodenum. That's the Billroth 2. In the Billroth 1, for lesser benign procedures, we can resect the stomach. You don't have to resect a massive amount, okay? And then we join up back the stomach with the duodenum. And that's a Billroth 1 because the normal stomach continuity is maintained. Yeah? So you have to understand the difference between a Billroth 1 and then Billroth 2 gastrectomies. So when you get into the hospital and surgery, you're going to hear them talking about Billroth 1 and Billroth 2 gastrectomies. Yes? So now that you understand it, that is so. So when we divide the first inch or so of the duodenum, remember the first part is 2 inches, the superior. The superduodenal, the branch from the right gastric, and the retroduodenal arches from the gastroduodenal are going to be divided and ligated to free up the remaining inch of the first part of the duodenum, yes? To close off. So that part of the duodenum which is left going to be closed off at this point here now. How many blood supply is it getting? This is all in the first part of the duodenum. Huh? How many arterial supply to this stump? That's normal, but this is not normal. The surgery makes it abnormal. So it's only 2 arteries now. The pancreatic or duodenal arteries, which are just coming from all the way down here and have to come all the way up there. So what can you say about the viability or this portion that you saw of the duodenal stump? You can see where it's just prone to ischemia. Right, prone to ischemia. So we have to close that off very meticulous at surgery and very careful. Because of this tenuous blood supply, leakage may happen. And when it leaks, all that bile and pancreatic juice is going to leak out into the general peritoneal cavity, while a blown duodenal stump. And that's not a nice situation. You understand? Because that patient is going to take longer to recover for that hole to close off. In spite of leakage, I always can say the thing really, it's like you see the water. When an underground pipe bursts, you see the water is welling up through the holes in the ground. We can see that, as it were, by where we saw, you know. But everything becomes so edematous that if you try to put another suture into that area that's leaking and tight, it's going to even make it worse, tear it out more because it's so friable. So we can't. We have to allow nature to make it heal. And this is where it's going to leak for some time, and the fluid's going to leak where to. Which area of the body is that fluid from this leakage going to be? Which part of the body? From yesterday's, from the peritoneal. Right, into Morrison's pouch. So at surgery, we have to put a drain now, an active sum drain, that we put on suction, continuous suction, into Morrison's pouch. So you see why we need to know the anatomy. Yeah? Yes? No, this guy is a Billroth 2 he has. But when you feed him by oral route, all of those stimuli for gastric and pancreatic and biliary juices are going to be there. So all that pancreatic and biliary juice is going to even leak out more. So we can't feed the guy, but we need food for survival. So you're going to feed this guy for survival now. We bypass the stomach and go by the jejunum and put a tube in the jejunum, a feeding jejunostomy tube. Yes? And we put food into the jejunum. So what type of food do you think we're going to put in the jejunum? Remember, we can't put any tube in the stomach, you know, because the pancreatic and biliary juice are going to be stimulated. Eh? What type of food do you think we're going to put in the jejunum? It's a solid food like what we had at lunch today. Like a jerk chicken and rice and peas we put in it. Huh? In the jejunum? No. The jejunum, the food has to be liquid. Because that's what the stomach does to all of it. Right, Anton? And enjoy this jerk chicken and rice and peas today, right, Anton? It has to mulch up and break down all those big particles of food. Just into liquid, the chime. So it has to be liquid. And every 20 seconds when the food has been converted to the right isotonicity, 2 to 3 mils of chime is flipped out from the stomach every 20 seconds. And that's what we have to mimic in the jejunum. So not only put in the tube, the food that has to be there, gonna have to be liquid. Yeah? Like your ensures and your shakes, yeah? And the food that we give in, you know, the ensure and the shakes come in 250 mils or so. We can't just get the bottle of 250 mils and squirt it in. So, you understand me? We can't. You've been to the hospital and seen the people getting drips. We have to give the liquid in drip forms, small drops. Yeah? And we explained here already the reason why. If you should inject that big bolus of Ensure shakedown into the thing, the food in the jejunum is going to be what tonicity? Hypertonic. And by the law of tonicity, food osmosis, yes, liquid is going to move from the circulation into the gut to try to make it isotonic. You follow? So when you pull out all of that fluid from your circulation, what are you going to feel? Right, you're going to feel drowsy and lethargic, and itis comes in. You know what they call itis?
No.
I never heard that term. No, he's an Indian, you know.
It's missing a piece now.
So, how you really never hear about itis before? As your colleagues.
Can you complete the word first?
Some people might feel offended, you know, because there's just this guy this morning, I don't know if he was offended. The Chinese got brought at the back, you know. I was
He
asking,
wasn't. I don't think he was.
but as I soon, I was asking him if he knew any martial arts, and which the Chinese also, and he said no,
He
and
was. He just didn't
he
care.
just disappeared after that, you know. So I don't know if he felt offended that I picked out on him.
Post-prandial.
You know, some of the guys out there were touching, you know.
I just like that.
It's like you know in martial arts, and you know in the by genetics. You know Bruce Lee?
Yeah, man, I've seen his movies.
Have you met him?
That's what his movies. Anyway, back to here. So we cannot do that, you know? Plus, all of the Ensure with that big volume one time, the sugar was going to be happening to the sugars, the blood sugars. Right, the sugar then be reabsorbed, high blood sugar, hyperglycemia. The pancreas is going to sense that. They're going to put out more insulin. The sugar was up there, the sugar going now with the insulin, now it's going to plummet down, zoom. Yeah? More insulin, relatively speaking. And again, you're going to get the itis running. You know, like after lunch, we always want to. That's why I was always sleeping. Until
messaging me about it.
yeah, until Mr. Gardner keep waking me up, you know, after lunch. Itis said it, isn't it? Okay, so you understand the blow duodenal stuff, eh? Now, there's a characteristic problem, not problem, anatomical feature of this first inch of the first part of the duodenum. The first inch of the first part of the duodenum. What is the characteristic anatomical feature about it? There's plenty of features for that matter. Firstly, on the outside, I think Mr. Gardner was having Anthony rubbing this aspect, no, sir? He was rubbing this aspect. Was that not? Yeah. He was rubbing this aspect of the stomach here, the pelvis region there. Yes, and asking him what was he feeling there. Right, he now remembers. You see why? Feeling is believing in. That's why we get so much strapping when we're younger. Feeling is believing. So I'm hinting the first part of the duodenum here, the first inch. On the outside there, I'm rubbing it. And I'm rubbing it behind there. what is peculiar about the first part of the duodenum compared to the first inch of the duodenum compared to the rest of the duodenum? Right. It has duodenum both and its anterior and posterior aspects, right? So Anthony will not forget
The
that.
first 2.5 centimeters,
Yes.
intraperitoneal.
Yes, it's intraperitoneal.
And Patrick, can I ask you,
Yeah, man, sure.
The first 2.5 centimeters of the duodenum is what? Intraperitoneal. What is attached to its superior border?
Yeah, I was going to ask him, what is in the continuum? Which,
Hepatoduodenal ligament. What's
Right.
another name for the hepatoduodenal ligament? You have to know this because it comes all over the exam. No. What's another name for the hepatoduodenal ligament? You must remember this.
you know, man, you all know.
Edge of the lesser omentum. What's another name for the hepatoduodenal ligament? Edge of the lesser omentum. Anthony, how are structures situated in there? Anteriorly and to the right.
Anteriorly to the right will be over the first part of the duodenum.
Lord, man, just show you. See the thing right there? Anteriorly and to the right. See the thing right there?
Come on by a lot.
CBD. Anteriorly and
by
to the
look.
left.
Anterior to the left. Come.
Come on, we have to
It's an
sharp.
artery. It's an artery. It's an artery. Come.
Hepatic artery proper.
Correct. And then posterior to those two structures.
It's a vein. It's a
Here
vein.
it is. HPV. What does HPV stand for?
Human
Right.
papillomavirus.
And where is that from?
Y'all making
Posterior to the what? Neck
To the
of the
neck of the
pancreas. That's the most important thing. You see that young lady, Melissa?
Yeah.
You want her to report to the rest of her friends that you're sharp.
Right.
Very good. Melissa?
Not too sharp now.
Okay, and we're still by the foramen of Winslow, yes?
See there?
And the
Look at
structure
that.
now. What is the structure that I've lifted? Are you seeing it there? Are you seeing it? The structure.
Work myself towards anterior because is that the hepatic part of it?
No, because
Hold on there.
Patrick, you're fairly clear.
the ligament.
Yes, I don't want to match up
So
this.
the anterior, the ligament is anterior.
This structure here. All of this structure. Are you seeing it, guys?
Doesn't look like it's
What is that structure? What is forming the posterior boundary of the foramen of Winslow?
RBC. Okay.
IVC.
Right, you see that? That's the inferior vena cava, that's there, yeah? All right? Now we have the IVC there. And Mr. Gardner had showed you the hepatic portal vein. Where is it on
Oh, right
this?
here, Patrick, here. Turn him like this one.
To show you better.
Okay, give it to me.
Yes,
Yeah.
good.
As in,
Yeah.
take the
He had showed you
portal vein foramen IBC.
the structure here. You all saw that, right? This is, what's this? Right, this is the hepatic portal vein. Yes? And this one back here, here is the
And you
IVC.
can see the foramen of Winslow. Look at the opening. See the opening right there? Take a picture of it.
Yeah, you see that? And why I'm highlighting that to you guys is that, you know, these guys, like, they tend to drink and try to show off.
Right.
It's just really show off, you know. So who can drink the most? And hold them liquor, you know?
You only Trinidad, they like drink a lot.
Yes, man. From my friend, a friend of mine that followed West Indies cricket in the glory days, you know. He was Viv Richards' best friend, this Jamaican brother. Some of them might know who I'm talking to. Anyway, he said when he got to Trinidad, The first thing that hit you at the airport is two things. The smell of petroleum and whiskey. When you hit Trinidad. Two things when you reach the airport. The smell of two things hit you.
You
The petroleum, the
petroleum.
gas, the oil, yeah? And the next thing is whiskey. Because in Trinidad, them guys drink whiskey like how we drink water, you know? Don't they?
It's Brandon.
Yeah. So they show off and they end up with cirrhosis of the liver. And when you get the cirrhosis of the liver, they get portal hypertension. And you see that portal vein there, this one here, it's small in relation to when you get portal hypertension. Because of all of that blood, you know, from the gut is there, trying to pass through the liver, but it can't go through the liver because of the fibrotic reaction. So the portal system is going to become high pressured for one, can cause the varices, etc. But the vessels become much larger. Yeah. And sometimes when the patient has the varices and bleed, to reduce the pressure from the portal system. The portal venous pressure, you have to know the numbers, it's about up to about 20 centimeters of water. But with portal hypertension, it can go much higher, 40, 60. Yeah. So reduce the pressure to reduce the incidence of varicose bleed, for instance. They now have to reduce the pressure in the portal system, and what they do is join up that portal vein there to that vena cava that I showed you just there, right at that point, so-called portocaval anastomosis. And we can do the anastomosis by side to side. Yes. We can close off, divide the portal vein, its proximal part, go into the liver, close off that, and then bring the stump and join to the inferior vena cava. Okay? So we have the portocaval shunts. And this is where they refer to these portocaval shunts as non-selective, because they just reduce the pressure to that level that there's no flow of the portal thing through the liver. But another group of Americans, they have dissected out that splenic vein which you all did see, and join that splenic vein. Remember the splenic vein will join something to form the portal vein, don't it? What again? Right, the superior mesenteric. So you see the splenic vein is a part of the portal system. So they will join the splenic vein to the renal vein, which is nearby, the kidney is nearby. Okay, I can show you.
Splenorenal shunt.
Splenorenal shunt. And splenorenal shunts are described as selective. Yes, it reduces the portal venous pressure, but it does not totally remove the flow through the liver. It doesn't dramatically lower the pressure as the portocaval shunt does. You understand me? And why I'm telling is that the amines, when you eat and so forth, they go to the liver in your food and are converted into proteins, etc., right? To food products for storage. But when this can be done in the liver, these amines act as false transmitters. You understand me? So suppose a man like me now should get that surgery done. You have these false transmitters circulating around. And whereas I'm talking and joking with the girls, anytime you see me start go around like Gardner and hug up the girls and touch them up and things.
What the hell?
you know, it's a different story. And this is what these shunts to do to individuals. They have changed the, what is the word, personality. A change in the personality of the guy. You have a new man. Understand me? Anyway, these are some of the complications of these surgeries as a result
What
of.
about the nutritional aspect now? If you know bypassing now the the liver now. So you do a shot, they take HPV and you're putting it into the IVC. What is happening now? Because you're basically depriving the patient of everything.
Yeah. First, to answer that, people who did drink never ever did eat well when they drink that degree. You understand me? Because 1 gram of alcohol provides how much calories again from your biochemistry is 1 gram of alcohol. And that's why I don't feel hungry when they drink. Provides seven calories. 1 gram of carbohydrates, the sugars that you eat. How much calories? You guys don't you supposed to have done
Somebody said
biochemistry?
3.4.
Huh?
Somebody said 3.4. He said
4.
See? Close.
So yeah, it because at your stage if you're going. So you see why they drink. When they drink, they don't feel to eat, and it's just easier to just sip that down than have to have the trouble of working to choke the food.
So they have to drink, they have to feed on alcohol for the rest of their life.
Not feed on it, but that's what they do. The guys, the alcoholic guys, they drink, and that's why they stay in that vicious circle. You understand? And the real alcoholics, you never seen them as a strong, muscular guy like Gardner. You understand me? Or like,
No, he's a muscle man, yeah.
yeah. You understand? So they never become too well nourished. That is it. So that's the difference, no, right? The rest of the duodenum is covered only on its anterior surface, yeah? It's reflected on medially over the pancreas.
So Patrick, just stand back, just keep it like that. So students, you see those vessels and you can identify them?
Yes.
Wait. What is this one? Sorry Patrick, what is this one? My apologies. What is this guy? Common
Artery.
And what is this man coming down here?
Gastroduodenal artery.
Right, and this guy going up.
Proper hepatic
And
artery.
this guy down? This guy down?
Hepatic.
The cystic.
This fellow. And this fellow here. Who is that? Who is this guy?
Cystic duct.
Right, good. And then you can see that's the common, and then this fellow here is the what?
Proper hepatic
And
artery.
this boy?
Left.
No, to the right. That's the left. Oh, sorry, Patrick.
Whilst Gardner is still alert, Gardner dissected a nice specimen, and I'm asking him to get it. The stomach,
The crow's foot?
yes, the crow's foot.
All right.
You can get it for
Yeah,
us.
man, right now.
You all hear about this crow's foot, don't you? Now you need to see it. He has everything in it. That's why I work with him. Anything I need, he gives me.
Lodenqai, can you show us the foramen of inside again so I can take a picture?
You're feeling like a
Yeah,
You cut him zippy for you?
Thank you.
Okay, so the duodenum is covered by peritoneum, yes? And when it comes to the second part of the duodenum, it's reflected, the peritoneum is reflected laterally, yeah, to the right. And the kidneys should be here, forming this impression on the liver. It should be reflected on that because over this vicinity will be the hepatorenal pouch of Morrison. Yeah? Now, in actual life, hopefully, we're going to ask the guys, our next lab with is what, Wednesday? When we do intestines, small and large. To surgically to attack, to get at this duodenum, second part of duodenum, we'll have to incise the peritoneum laterally to the lateral border of the descending second part of the duodenum. Incise it, yes? And having incised it, the whole surgical procedure of incising the peritoneum to mobilize the pancreas, the head of the pancreas and the duodenum is called whose procedure again? Or maneuver? No.
Wait, what was the question?
To mobilize the duodenum and the head of the pancreas so that we can lift it up like that and get our hands behind it like this.
Yeah, we're trying to mobilize the
Keys?
We told you that it's called the Cocker's maneuver or procedure.
Cocker's
Kocher, another German surgeon. The Cocker's. You understand me? And when we do that, we can gently elevate the descending duodenum and the head of the pancreas, yes? Like that. From all of the big vessels that are running behind here. You can see some big vessels running behind here. The aorta and inferior vena cava are running behind here. So this plane that we get into, in elevating the duodenum and the pancreas, the head of the pancreas like that, we get into an avascular plane. Yeah? No bleeding in spite of those big vessels nearby. And what we call that plane that we
Line of two.
eh?
Line of two.
Not quite. This, what they call the ligament that hold up the DJ flexure again.
Trays.
So what we call this avascular plane. Eh? Avascular plane of same traits. I say traits. T-R-E-I-T-Z, whatever you want to pronounce it as. You understand me? The avascular plane of traits. So when we need to resect duodenum or operate on the descending duodenum or the head of the pancreas resection, we have to do this Cocker's maneuver and then we get into this avascular plane. How is this avascular plane formed? Remember we said in real life that the whole gut was a midline thing, didn't I tell you that? And it's usually suspended by a ventral and a dorsal mesentery. Most of the foregut mesentery, the ventral portion disappears. Eh? Most. Yes.
Seems like it might be upstairs, so next lab I will take it out.
All right, please
But
do.
I'm seeing the carry bucket upstairs.
All right.
Yeah, but don't sit right here.
So we told you what was going on. This pancreas developed from two portions, right? It develops from a dorsal bud, dorsal in relation to the gut, eh? And a ventral bud. The ventral bud rotates in that direction to ultimately fuse with the dorsal bud. So the whole pancreas now becomes one. Yeah? But the main pancreatic duct, which is running through the pancreas, then dips down to become continuous with the ventral bud. Those two ductal systems form, and that will form the main pancreatic duct of Warsaw. You understand me?
Yeah.
Whereas the other one persists as a lesser, the axillary duct of Santorini. So while that fusion of the two buds happen, the duodenum is still rotating back and back, like that, yes? And the ventral mesentery that was suspending the duodenum, not the ventral, the dorsal one, and the duodenum and the pancreas, it now become fused with the posterior peritoneum, parietal peritoneum. Yeah, become fused. It's avascular, and it now constitutes the avascular plane of trites. You understand? So you see how it comes about. Now, the important thing for you about the second part of the duodenum, and surgically, if the endoscopist will tell you about a duct stone, common bile duct stone impacted in the duodenum. Yeah? if the endoscopist failed to do his thing and get the stone out, then the surgeon has to go in. So at this level here, we would do the cockers maneuver first.
It migrated upstairs, yeah?
Yeah, like
To the
a
next
funny
floor.
Yeah.
Sure. Is it get on? Jungle.
Dominic, what time is it?
Soon midnight.
It's just 5 o'clock.
Soon midnight.
Oh, 4:02?
It's
Oh,
5.
thanks, guys.
So we do the cockers maneuver
It's
first,
5:06.
yes? And then we open the duodenum, yeah? This is the singing part of the duodenum. And on the posterior medial aspect of the second part of the duodenum, you can see this nipple, yeah? The major duodenal papilla, and that is where we will see the stone impacted there. Yeah? Right, you showed me a nice one, yeah. Where is it? I thought you showed me a nice one. Anyway, wherever it is. Okay, so there it is, the major duodenal papilla. And how far away is it from the pylorus?
10
Right. And going more proximally, you see another one, another papilla. How much of a distance? Right, 8 centimeters from the pylorus or 2 centimeters above that. That's the minor duodenal papilla, yeah? Okay? And at the minor duodenal papilla, we say in some individuals, the opening is too small for the degree amount of secretion that's coming there. Right? And when that happens, what will the patient get? When the minor papilla opening is too small for the amount of secretions that are going through. Yes, and will cause rupture of the ductal tree, and what clinical condition will happen. I told you acute pancreatitis, man, which is not a nice thing. So they have investigated patients with recurrent pancreatitis and found, that there's narrowing there. You can always endoscope the guys and inject contrast into both major and minor papilla. And that's how they found it out. And when the duct system is too narrow there, what do they call it again? We told you the name, pancreas divisum. Understand? And all we have to do, endoscopists can solve the problem once they find it, is to divide this minor duodenal papilla to make it wider. Eh? Or if he fails to do it, we the surgeon have to do this. Open the duodenum there and inside. Okay? So that's the key thing to remember. Now, the other important thing is at this point here. So see where we are, guys. Pylorus first part, second part, third part with the head of the seal with the head of the pancreas. Eh? What is crossing this third part of the duodenum at this junction here?
Superior mesenteric artery.
All right, the superior mesenteric artery is crossing it there. Eh? Mr. Gardner told you, and Tony reinforced it, that the superior mesenteric artery is coming from the abdominal aorta. Where again?
Below the level of T12.
At
The
L1.
lower one of T12.
L1, right? L1. But you won't see its origin, as I'm showing you now. You won't see its origin from the abdominal aorta there, because what is overlying it? Don't you see something overlying it, man? But you're not seeing it.
The artery.
Yes. See the artery here, it's this big thing. The vein is always on the right side, and the artery is this bigger one. What is this thing there that's blocking the origin that you don't see it? What is that? You know, see, guys? You see it? You see the duodenum? You see the duodenum coming around? And it's being crossed by the SME Where's the little red thing gone? Anyway, this is big on the left side of this these structures. This bigger one, you see it? That's the arch is always the big tough one here. That's the SMA. And the origin from the aorta is being obstructed by this guy here. This is a part of the pancreas, man. And which part of the pancreas? The neck. And if we should retract it out of the way. Now, with a little cleaning up and so. Yeah? You can see the aorta. It's behind the aorta. And it's coming from the front of the aorta at this point. Okay? Good, so you see that. Now, the problem is that this SMA can compress this duodenum third part, and it has the so-called nutcracker effect, because between the aorta and the vertebral column which the aorta is resting on, yeah, that's all right. It's like that. It's being compressed between the aorta. You see the aorta and the SMA, the duodenum. Third part is being compressed. Nutcracker effect. Whose syndrome is that again? Multiple names. Wilkes, Rokitansky, duodenal compression syndrome. Yeah.
Wilkes, Rokitansky.
Rokitansky first described it. Then Wilkes subsequently.
Oh, two different names?
Yeah, man, two different people. All right, so you see, guys, all right? And it tends to happen in which gender?
Female.
Females. And which type of female? Like she or she? Right. It tends to happen in tall, slim females, eh? This Wilkie syndrome. This
Which kind of female?
tall, slender,
Taller than what?
slender, slim females, you know. And the critical angle at which the syndrome occurs is when it is said that the angle between the SMA and the aorta is what angle? You guys ever go bingo yet? What? You guys missing everything. You never need to go bingo when you become parents. Eh?
Sunday bingo. Sunday bingo.
Yeah, man, you should all go bingo and have fun one day.
Where do you have bingo?
All go to place in Jamaica bingo.
Where do you play?
Or wherever they said they have it.
Do you gamble?
Huh?
You gamble?
It's a form of gambling, but that's, nothing major gambling. And when they look at the things, they say, like, I know BI was 50, That's a B. That's a B. And then it's a B. It's a legs in bed. You know what legs in bed is? What number legs in bed is?
L4.
You can imagine Melissa in her trousers there in her bed. You see legs in bed, man. What number do you see? What number do you see, Anthony?
Oh,
I see.
Yeah. Exactly. 11. So they did measurements and found that the critical angle was at 11. When you have 11 or less, the more risk of developing the syndrome. Above 11, you're all right. You follow? And the treatment of this compression syndrome, what is the treatment now, Tony?
I'm not sure. Looks like resect the trite. I think the trites. Do you cut the trites ligament? Like you just cut it and then bring down the.
So what? Yes, he wants the suspensor ligament of trites or treats or trites. That's what he says. You find it, you dissect it out, which probably has been dissected already. Yes. And what you do to this suspensor ligament? This is the treatment,
Okay, just cut it a bit.
You just divide it, man.
Cut it to let the ligament
Yeah,
descend.
yes. Because if this is the angulation, the 11, and the duodenum is being compressed, but the duodenum, remember the DG flexion is being held up by the suspensory ligament. So if I cut the ligament at that 11-degree angle still, what happens? You see it fall down to a bigger space between. You follow? So that's a simple answer how to treat it by the suspensory ligament. You'd have to trouble the gut itself or the blood vessels. Eh?
Yeah.
Just to find the ligament of choice and divide it. Eh? Anyway, fine, that's
It's not 6 o'clock yet.
Good one, guys. Good one.
Now in the past, in the past for the students, I guess the students are different, We'll go till our 4:30,
It's 4:30 somewhere.
Huh?
It's 4:30 somewhere.
I'm talking here. See, you're that. But it depends on how interested you are and want to learn more. We guys always want to learn more from the courses like Gardner.
Maybe if it was a Friday. Maybe if it was a Friday.
All right, so Tom, make sure you find the course for us. Just when next week Wednesday. Next week Wednesday.